So very first item we have here is the most common way you are going to see prioritization items asked or framed. And that is going to be trying to identify the client that requires your attention first, okay? So always look closely at our header and stem and see what is it really asking us. So this item is saying the nurse should first assess which client, okay? So we're looking for who is most ill, most sick. So let's go through our options. Option 1, we have a client who is obtunded on hospice care and is becoming restless. Option 2, we have a client with a cholecystectomy 2 hours ago reporting nausea. Option 3, a client with a peptic ulcer with a rigid abdomen reporting sharp abdominal pain. And option 4, a client who had abdominal surgery 2 days ago and now has left lower extremity pain and swelling. So let's take a look at these just a little bit closer. So option 1 is a wonderful opportunity for us to remember a very important test-taking strategy. Don't latch on to just a keyword, okay? That's a good way to get yourself in trouble when you're doing any type of items, but especially prioritization. Because if I saw that all of a sudden a client is obtunded and they're becoming restless, they have this change in mental status, that could be very concerning. I might be worried about stroke. I might be worried about hypoxia. But in this case, I have to look at it in the context of what it's telling me, okay? And that is I have a client on hospice care. And remember, a client on hospice care is going to have a terminal illness. We anticipate that as they get closer to the dying process, their mental status is going to change. They're going to become restless. So for a client on hospice care, is this change in mental status expected? So I'm going to go with 1 is right here in green with expected finding. So that is a low priority, okay? Option 2, I have a client with a cholecystectomy 2 hours ago reporting nausea. So do we anticipate nausea? Well, let's talk about this. Anytime we send a client to surgery for any reason, anesthesia medications can cause nausea. In addition, this is a client that just had abdominal surgery and they had their gallbladder removed. And we know gallbladder problems alone can cause some nausea. So once again, this is a very expected finding for this client. So we're going to put it right up there with the other one. For the very top of our pyramid, expected finding is going to be option 2. And then option 3, I see you guys love. So let's talk about why y'all might be right. So we have a client with a peptic ulcer with a rigid abdomen. So I want to tell you guys, anytime you see the words rigid abdomen, or you might also see the words board-like abdomen, firm abdomen, all these types of things, hard, it's going to be a big red flag to you that your client potentially has peritonitis. And the reason I went ahead and just told y'all that is I see a lot of y'all are typing it, so y'all are already on the right track. That rigid board-like abdomen is an indicator of peritonitis. Also, whenever they have that board-like abdomen, they typically have some sharp abdominal pain and discomfort. So peritonitis, if left untreated, what do we anticipate will happen? So what is going to happen if we leave peritonitis untreated? So we see this client with a rigid abdomen and we're like, oh, they're okay, and we leave them. What's going to happen to them? Infection? Yeah. So that's what we're concerned about. Remember, peritonitis is that peritoneal cavity, okay, in the abdomen, and it gets inflamed. And I see a lot of you guys saying rupture, shock, septic shock, and y'all are 100% right. So that is, if you leave it untreated, you can anticipate that soon you're going to start seeing signs of shock, such as tachycardia, hypotension, pallor. They might become diaphoretic. And this is a life-threatening emergency. So that is certainly going to be a circulatory issue. Option 3 is circulatory. So it's much higher priority on our pyramid here. But let's look at option 4 and make sure that this is in fact the highest priority client. So option 4 is abdominal surgery 2 days prior with left lower extremity pain and swelling. So anytime we have a client that is post-op, chances are they're not as mobile as they usually are. So they're probably laying in bed and now they have unilateral pain and swelling. So what do you guys think is going on with option 4? What do you think this client is experiencing with unilateral pain and swelling postoperatively. We are anticipating a DVT. Very good. So DVT. So DVT is also a circulatory issue on our pyramid. So that's where it could be a little confusing. You know, they're both circulatory issues. But we have to just look at them and put them in context. With our DVT, we are still having just localized pain and swelling, whereas untreated peritonitis is going to lead to a systemic circulatory issue. So we have circulatory issue in just the leg versus circulatory issue that's affecting perfusion to the entire body. So you guys are 100% correct with option 3. But let's talk about when option 4 could have potentially been correct. Maybe instead, the option could say, we have a client that's postoperative who has left lower extremity pain and swelling, and now they have tachycardia. They're restless, they're anxious, they're short of breath. What do you guys think would be going on then? If we had a client that has a lower extremity pain and swelling, and then now all of a sudden they're having dyspnea, they're having anxiety, what might be going on? PE, very good guys. And so we know PE is a breathing issue. And so in that case, that would be our highest priority. So someone asked, made a great comment. I just want to point out that they said DVT is expected after surgery. So I want to tell you guys, be really, really careful. When we're saying expected findings, we're meaning something that is normal, that is not a complication. So even though DVT commonly occurs, or I shouldn't say, let's hopefully not commonly occurs, but even though DVT can occur postoperatively, it's not expected because we don't expect a client to develop a DVT. We hope they don't. We certainly do interventions like, SCDs, blood thinners to try to prevent it, but it's not expected when it's a complication, okay? I just don't want you guys to get confused. But y'all seem like you're doing a phenomenal job. So we can see once again, option 3 is correct, and you guys did great.